So, without further ado, let me introduce your next speaker, Dr. Mary McNaughton Collins. As a PCP and clinician investigator at MGH and an associate professor at Harvard Medical School, Dr. Mary, as many of her patients call her, is a strong advocate for shared decision-making and has been working with her team to really bring it to life and to ensure every one of her patients is empowered to make the right decisions for them. She earned her MD from the Brown-Dartmouth Joint Program, her MPH from the Harvard School of Public Health, and has been widely published. Today, she's going to talk about a day in the life of a PCP, what it's really like to deliver primary care, and how to leverage so much of this great technology and support at the coalface. Dr.
Wow, thank you very much. Honored to be here in my favorite shirt, apparently. I just saw that it looked like the same shirt from that photo. Indeed. No, actually, I have lots of pink shirts. As the Health Dialogue folks know, I just wear one every single day, but it's not the same shirt. I'd like to thank Tracy for the invitation to talk about boots on the ground, as she says. So I did, in fact, wear my boots. I've got boots on the ground to tell you today sort of what it's like about some of the challenges to incorporating population health management and meaningful use into our practice. I'd like to first say that for myself, I'm a primary care doc first and foremost, and I also do clinical research in outcomes, and I work at the Informed Medical Decision-Making Foundation, where shared decision-making is at the heart of what we do, and I'm able to practice that every day with my patients and actually even prescribe decision aids, et cetera. So let me next talk about my practice, describe it, and then what I'd like to do is talk about, tell you three stories, three transformations, three changes that are happening pretty fast in our practice right now, and then to end with actually, I think, some hopes and dreams and end on a positive note, because things are, we're starting to see getting better. And I'd like to applaud the panel here earlier because it really resonated, and also to applaud the report that you have from CCA and Health Dialogue because it really does resonate with what's going on with us right now in terms of the docs knowing the population health management is important, but not exactly knowing what it is or very familiar with it, but and feeling the upfront clinical burden and increased time to make it happen, and asking for support and help from our management teams to help us do this in our practice. So my practice, Internal Medicine Associates, there's 15 practices at MGH, and the IMA is the largest. There are 50 staff physicians, and we also have a lot of medical residents and students who come through. We've got, in FY11, 31,000 lives, and we had about 75K visits. And we're pretty hardcore internal medicine. There's less than 15% of folks who are under age 40, and about a quarter are over age 70. And interestingly enough, as I said, we're the largest practice of the 15, and when we get these report cards and performance measures, and if we don't like them, we just always say, hey, our patients are sicker and they're more complex, so we're not really going to pay much attention to that. Well, we actually recently got a risk adjustment score that showed, we're not that competitive at MGH, but that our practice is the sickest and most complex. Don't ask me about the risk adjustment. I just like the outcome. I like the score we got because it makes me feel better to know this. So our practice at MGH is changing fast. And it's actually changing wicked fast, or at least it feels like that to me. And we're moving to be more patient-centered, and that's excellent. We're moving away from the volume, the productivity, which has really driven us crazy these last years, where it's sort of like that classic Lucille Ball episode with the chocolate factory, just cramming more patients into our sessions, just faster, faster, faster. And so actually it is refreshing that we're hearing that we're supposed to be paying attention to our patients and their outcomes and the quality of their care. And our practice itself has actually started to make some of these changes to enhance the patient experience. We have evening hours now, 3 nights a week. We've got our own urgent care within our practice so that we can decrease ED utilization and offer same-day appointments. We've got a diabetic teaching nurse, a nutritionist, right here on site. And more recently, our electronic medical record is allowing patients to get in, view their labs, communicate with the office electronically. And so again, this is a great thing, moving patient-centered. However, these changes are not always met very well from the physician side. I don't know if you've noticed, but we docs are not great at changing our ways. We hear we should be nimble, we want to be nimble, but we're sort of like the Tin Man, and I do think that our physician leadership, our hospital leadership feels like they're running around with these oil cans just trying to get us to be able to change our ways a little bit. And so with that, what we end up having are these physician incentives that, to do what actually we should be doing. And it's almost embarrassing for primary care physicians that we need these incentives to open our email, and the bar is lowering all the time. Open your email or don't delete your email and you get a prize. And also, and even now, I feel badly because there's so many new training sessions and rollouts, and so we really need to be reading our emails and so that we're not caught off guard like we repeatedly are when a new rollout comes, but we just learn about it when we're sitting there with our patient that day. And so we're now getting these emails that say, and again, this is physician leadership, we should be opening these messages, and that it says an important email is coming, like, no, open this email, don't delete it. So then you read it, because I better read it, and it says there's a very important email coming in 2 days, and this is going to be the title, and there's an action item. And so, I mean, so this is who you're dealing with, folks. And this is just happening this week, seriously. On my email say, don't delete. I'm like, okay, already. And then the other thing is we're starting to notice the change in lingo. We used to be recommended to do a training course or requested. Now, good heavens, they are just mandates. We are mandated to do this and mandated to do that. Thou shalt, take a training course. And so again, it just goes to show we're not great at changing. Hopefully we can, but with that, the stress is sometimes palpable. And you might ask, why are we primary care docs in our practice, a bunch of donkeys on the edge, like from Shrek? Why are we so stressed? And I'd like to acknowledge that, at least for primary care docs, we went into medicine because, get this, we like people. We like our patients. We like their families. We like their stories. And we do honor that cherished time. Granted, it's been shorter over the years, but we really like that time with our patient. And what's happened is, we have our electronic health record, which I do like the record that we have in our practice. We've had it for a while, and it's been excellent. And what would happen is, and we've worked that into the flow, so I'm not arguing that we shouldn't have an electronic record, and my colleagues aren't either. But what's happening is, during that 10 to 12 minutes, when I used to be able to work with my 87-year-old and their family, we're looking, sort of making eye contact, using the computer like we're taught now, what we found was that that was my patient's interesting stuff, her problem list, her med list. Across the top would be hematology results, radiology results. But, geez, within the last couple of months, again and again, we have this banner, and more things are being put onto that banner. Things that are on there are sort of quicksilver, instant messaging. So now I'm talking to my patient, and I'm realizing that I had a message 4 seconds ago. Now I've had 2 in the last 4 minutes. And those messages are pretty simple. It could be that the VNA called or the pharmacy needs something. I used to get those messages when I walked out, and it would be from my secretary or on paper. So now that it's on the dashboard, it can be distracting. And even meaningful use criteria, we've got a dashboard. We need to keep these criteria green, and sometimes they get into the red zone. We have so many things. Population health management, ours is called Top Care. That's there telling us, run your roster, send out your letters. And they're all there and sort of causing us to be a little bit of a distracted doctor. I drive like a Boston crazy driver, but I don't text and drive. But I actually don't like that I'm feeling like a distracted doctor because of all these things that just keep getting put on my electronic record. And again, they are good things. There's just so many good things to do that we're having some trouble with it. And so what I'd like to move to next is sort of 3 transformations that we're having that are happening right now. So the first one is awesome. So we actually have an innovation team. And so they're called our Tiger team. And within our practice, so again, we're fortunate to have this. There's one of the docs in our practice, a nurse, they've volunteered, and they are our PICs. They are practice improvement champions. And I do envision them. They're very tech savvy. They're all excited about new rollouts. I see them, at 6 a.m. meetings with their Frosted Flakes. Tony, the Tiger team, great. They're telling us it's going to be okay. But what they did was they even had us retreat. They said, there's 50 docs in our practice. And so, it's like herding cats. And so they said, we got to take you away for a retreat on site and 1 or 2 times. And so even if you had a patient session, you could cancel it and not even be held liable. You didn't even have to do a makeup session. It was so important. And even pay for the lights and the overhead. We usually worry if we're not there seeing patients that we got to pay for our overhead. So it was a freebie. We all got together, the 50 docs, and this innovative team made sure that we were all on the same page. We knew we were going to be patient-centered. We knew there's going to be a lot of changes. It's going to be painful at times, but it's all for the right reason. And that was great. So we come back, and what does our innovation team do? Some of them are my best friends, but I just say that the first project was we have to standardize our drawers. Because apparently, on our floor, the 50 docs, we don't all keep our gauze pads and tongue depressors in the same spot. And I mean, I went to medical school. Ooh, sorry about that. I went to med school. All I hear is, we got to standardize our drawers. And asking, well, and how's that patient-centered? How's the patient going to, notice the difference? Well, Toyota Lean says this, or PDSA cycles. I don't know, folks here in business like plan, do, study, act. We keep doing that lately. I'm like, I went to med school. I like the Krebs cycle. I like the menstrual cycle even. I like cell cycles, and I like cardiac cycles. I don't even know what this PDSA cycle is. However, the innovation team is so eager, and we're just like, it's going to be okay. We just have to hang in there with these folks. And in our practice, I've got colleagues who are rheumatology, whatever. You used to want to step outside your office and say, hey, I got an interesting case. Now it's just like, oh my God, what is that icon, and what does it mean? So the PICs are the ones that you tackle. I wait out. I see one go in the bathroom. I'm just pretending I'm waiting there, and they come out. I'm like, can you help me, write a visit summary report? I just don't know how to do it. So moving along now to the second transformation that's happening, and I think you've all heard about meaningful use. And again, at MGH, we're fortunate, at least within my practice, there's all different electronic records at MGH, of course. In a few years, we'll all be on Epic. But right now, we have one that's been working pretty well. So we could meet a lot of the meaningful use pretty quickly, except the visit summary report. The VSR is tough because we're just trying to write our own note of our patient during this 12-minute time. And now we realize we have to have this document that has to be ready for them at the end. And in theory, it's a great thing. The visit summary report, if you're a patient, you're going to walk out and you're going to get the problem list. You're going to get your med list. And ideally, if we docs do it right, we're going to type a little note to you. Oh, hey, this is your prednisone typer. Or, oh, you know what? We talked about your urinary tract infection. You're on these meds for 3 days. And if you're not getting any better or getting any worse, call me. Or, ideally, we would do that and personalize it. And then, however, we hear from on high that there are dollars on the table. And so they've figured out a way to do a default if we don't do it. What's the default? I mean, we've been in practice 15, 20, 30 years. As I said, our draws were crazy. And I forgot to tell you, the best part was the poor Tiger team was so excited about this drawer project, and we really weren't. But we went along, and there was a negotiation, and they allowed us all. We get one junk draw. Like, I swear to God, And people have been there for a long time, so, and they were going around taking photos of some of the docs' draws. I'm like, I didn't want to look at these draws. So anyway, where was I? Oh yeah, so meaningful use. So we're learning how to do these visit summaries, and like I said, if we don't do it, a default's going to happen. Oh my gosh, we just had a meeting last Friday, and I swear to God, this is going on right now. The default will just print out every problem list that's ever been there, so we're not able to tweak and say while you're there. People are saying, like, I gonorrhea treated 12 years ago. What? I came in for a sprained ankle. And literally, another patient had delusional disorder, and these are real things. And the doc was saying, like, oh my gosh, I never would have put delusional disorder. Like, I didn't want her to see that, but, she does have it. And so, and I actually wonder about, HIPAA or privacy because, all these problem lists. So now, talk about incenting a doc to make sure that they clean up their problem lists. We're working on that. So then the third thing that's happening right now, well, first of all, before that, so with the meaningful use in our visit summary reports that I've just told you about, so this is what happens with respect to that. 1 month ago, a lot of us are in practice. We have when you go to our homepage on our electronic record, there's your list of patients. And there's an icon on the side, and I'm looking at it, just popping in, seeing my patients. I'm like, what the heck is that? It looks like a basket. And I can actually hear some mumblings when I'd go out to do other things too. Other people are like, what is that? But we're too busy to figure it out. Like 2 days later, a PIC, a Practice and Innovation Champion or Improvement Champion tells us like, no, that's a sharpening cart. And we're like, oh, Christ almighty, a shopping cart? Well, why do I have a shopping cart? Like, I just want to write my notes. I'm trying to do my VSRs. You know, I'm trying to look at my secure messaging. Like, what's the shopping cart? But then, you know, and like I said, I make sure that I keep my PICs as close friends. My friend shows me, like, no, you're going to love the shopping cart. You dump in your visit summary report. You dump in your lab order entry. You even put your patient education materials in there, and then when your patient checks out with the patient care coordinator, they download all that stuff, and it's awesome. So actually, and I find that, like, I'm talking to my friend, and then there's like 4 docs. Like, we really are just on a need-to-know basis on this shopping cart. And so what do you know? We work it into the workflow, and we're actually going, you know what? We're liking our shopping cart. However, there's so much change happening so fast. Even our electronic record is getting grumpy and sluggish. And I had a feeling, because my shopping cart felt like that one with the wheel, and I'm like, oh, it was working well before. I don't know what's happening. And what do you know? We get the email that says, the shopping carts are broken. Don't use your shopping cart. And also, the labs, don't do lab order entry anymore. Go back to the paper labs just for a while. We're trying to do a quick fix. And the population health management comes in because this was part of why things were grinding to a halt as well. And I just felt so bad for the Tiger team because when they were cleaning our drawers, they knew that we were going paperless on the labs. So they had so many things planned for that part. And then, what do you know? This last week, I'm back to my labs out of my drawers. And so this is just where I'm just saying there's so many things happening so fast. We're doing our best to keep up. And in that email that said, your shopping cart is broken, don't use it. And again, it's that stop and start. Like, we finally got it into the workflow. And now we don't have it. And of course, we're going to lose those skills very quickly. We're the Tin Man, you know. We're going to need the oil can to figure out how to use it again when it gets up and running. So with population health management, on that email it said, and by the way, VSRs and all these things are important, meaningful use, but by October 1st, you've got to clear your lists docs. You haven't been clearing your lists. So we have just figured out, so for us, and I know it's going to get better, but the first phase of population health management for us is something called Top Care. And it's excellent. It's a list of cancer screening. So my patients, a whole list of those who are overdue for breast cancer screening, overdue for their mammogram, overdue for their pap smear, and men and women overdue for their colorectal cancer screening. And then I've got another list of all my patients with diabetes and who are overdue for an LDL cholesterol and overdue for an A1C. So this all sounds great, but the problem is that everybody, this is what it seems to us, a little whining here, that the doc has to act. And so they say to us, well, listen, if you just do a little bit of upfront stuff now, I mean, we're the people who can't even read an email or do what's right without a mandate. So they want us to go in and clear these lists. How do you clear the list? Well, you just say dead or alive, and or moved or not your patient. That's the first step. And it was really scary because when I went in with my patients with diabetes, Mrs. McGillicuddy, I'm like, oh my God, and it's not her real name. Miss McGillicuddy is dead, and what if it was an overdue LDL cholesterol? Oh my God. But it wasn't, thank God. So the other hard thing is I looked at my cancer screening, and I wanted to be a good doobie. So by October 1st, you know, I really wanted to clear my list. So I start going through, and I see that, you know, my patient needs a pap smear. These women have had hysterectomies 30 years ago, and it's in my note, but it's just not in the part of the note that these smart systems capture. So they say, oh, that's easy. Just go into your electronic record under this special spot and type in when they had their hysterectomy, and then you won't get that patient showing up again. Or with mammograms, the way we're being asked to do this is some of my patients get their mammograms done, say, in New Hampshire. They don't come back to Boston. And I know that. I have it in my note, all these years, but I just don't have it in the right spot. So I think that as we figure out how to do this, to have the docs going in and doing their data entry, I think it's not a surprise that the email that I got yesterday says, hey, we haven't even hit 50% of doctors clearing their list. Actually, we were supposed to clear our list by September 1st, but we got dispensation to October 1st because they knew we were dealing with our broken shopping carts. So our practice, you know, it was okay. And then the other thing is that while we want to be doing this stuff, sometimes, like I said, we really want to be with our patient, with our electronic record, and all these new things that are being put on there. It's not obviously clear to us that, for instance, colorectal cancer screening, I do shared decision making. I've talked to some of my patients, and they make an informed decision not to have a colon cancer screening test. Well, I don't want to be sending them letters saying, hey, why haven't you had your test? But that's the option. So the way we clear our roster, which is what we're trying to do right now, is we identify, as I said, dead or alive, moved away, not my patient. And then we have the option of sending a letter, reminder letter, or actually we think we're going to be able to have somebody call and troubleshoot. Because, for instance, my patients that I saw who had the A1Cs greater than 10, and I'm horrified, feel like a bad primary care doc, but I know one of them can't afford his medications, he's not taking his meds, and the other, she's got just such a chaotic lifestyle right now, she really can't prioritize, and if I just keep sending her reminder letters, I'm not sure how that's going to help right now, although I understand that this is a good thing and we all do. So in closing, what I'd like to just say is that I'm so encouraged by all that I saw today. You do joke about it, but I mean, you guys do have the solutions, we've got the problems, and I can't wait to go back to my whole practice, and especially the TIGA team, and tell them they're on the right path. After they get the draws figured out, I'm sure we'll be doing something that actually feels patient-centered. And also the fact that, learning that we're hearing that we're going to be getting more support, and we're working as a team now, which is awesome. So in a way, all that grumpiness that we had actually probably 9 months ago is actually becoming a little bit more of a morale because we have to work in teams. So we're having great team meetings now with the docs, the medical assistants, the nurses, and our patient care coordinators, our secretaries, all getting together, and we do these things that we huddle, and because we're told, is that a business school thing? I don't know, but we do these huddles now before our sessions, and we also sort of cuddle and snuggle because it's kind of a scary world with all this change going on. But so I would just like to end on a bright note saying that I'm speaking for myself, some of my colleagues as well, and it is difficult, but we're doing the right thing, and we're moving in the right direction, and don't give up on us. I know people like start here going to the providers. Please keep coming to the providers. We'll figure it out. We just got to suck it up and read our emails so we can learn our training and learn our rollouts, and we'll be all fine. So, thank you very much.
A couple questions. Do we have any questions for Dr. McNaughton Collins? Really? Ask her about the drawers. We have some microphones at the front of the room. We have time for 1 or 2 questions. Is your practice?
So it's Boston, we haven't had a primary care taking new patients, and I can't tell you how long. And the worst part is, my colleagues, there's 50 of us, but some of them keep getting out. And I said, one of my last docs to leave our practice, I said, you don't even have enough gray hair to be retiring. And he did say, I'm not retiring, I'm getting out. He had another opportunity, let's say. But the other thing I am saying is that we're trying to keep a good mood, though, because we don't want our residents and students to realize the stress that we're under because we're dying for them to go into primary care. So with them, we're like, oh yeah, it's so easy. Oh, it's so fun. You get a new thing on your electronic record every day. You open your email, you get a prize. Go into primary care. Anyway, it's crazy. You can't make this stuff up.
I had been a doctor myself once, so I can share your sentiment. My question to you is that this phase of our whole life seems to be a pre-marriage counseling. And my question is it going to lead to a honeymoon and a happy marriage or not?
And do you mean marrying population health management with primary care?
Now, marriage again is a very difficult question, as you know. I won't rather define it, but figure it out.
Okay. I'd say honeymoon and happy marriage would be the answer. Sorry, just a little bright up here. Yes?
Why do you have to clear your list? That you can't some of your nurses
Geez, you're just the person we need. So actually, that's what we do. I think they're sick and tired. I think we complain for so long that they don't even listen to us anymore. But actually, the best part about cleaning their lists, there are folks who say that the clinicians, they know the data. They can just do it better. But to be honest, the nicest thing is, I got another email that I just got before I headed down here from Boston, was that our medical assistants just got clearance that they're going to be able to be trained. Because I do think that I'm not the only one who knows dead or alive. I mean, there's other ways to see that. And so, yes, So that's another one of the good news, is that we're going to be having that. But again, I think where we've been clamoring too long is that when we move to electronic referral systems, in the old day I could just say, hey, can I refer my patient to podiatry for a diabetic foot problem, and my and our secretary or patient care coordinator could just do that. Well, now when we do it on electronically, we're doing that during the visit, but everybody wants to just ask us a few more questions. So now it's like, hey, you get the doc's attention. Is your patient on Coumadin? Does your patient have sleep apnea? And if we don't fill in every single one of those, the referral doesn't go through. And the same thing with our watch lists, every lab that's ever been done. Now it comes to this big list, so we have it there, but it does feel like maybe some of the normal labs could be screened. So again, it's a work in progress, but right now, that's where we are complaining that everything seems to need our touch. And yes, indeed, we're the only ones who can clear these lists by October 1st or September 1st.
One final question.
Sure. Hi.
Mary, thank you so much for coming today. As this industry has done this change in the health insurance space and with large aggregated populations, and you brought a great view of what it's like on the front line in primary care. Thank you. As we bring our Tiger teams to your aid, and we bring our resources to your aid, what's one bit of wisdom you would give us as we assemble our Tiger teams as you've lived it?
Right. So I would say, first of all, pick and choose carefully who it is that you're working with in our practice, because if you run into a barrier from the docs, I do feel like our leadership gets it. I think that they are understanding, which is why they are cutting us some slack. So I really do want the Tiger teams to meet, but I'd be afraid if you bump into the wrong folks, because there are still a lot of naysayers. I think the vast majority of us are open-minded. We're going to figure this out. So I'd just be careful. That would be my only thought, because I would love the Tiger teams to meet. Over breakfast, Frosted Flakes, you go. Great. Anyway, Chris, so thank you so much. But it's great. That's why I have come here. When I go home, I'm just really going to be pretty excited to get back and tell folks about this encouraging conference and all that I've learned. Definitely hopes for the future. All right, take care. Yeah, thanks.
You were amazing.
Oh, thank you.